So this is Robin Reedy. I'm the executive director for NAMI Nevada. That's the National Alliance on Mental Illness. And we have 3 affiliates here in Nevada, the Western Nevada affiliate, the Southern Nevada affiliate, and the Northern Nevada affiliate. And I want to give kudos out to the Southern Nevada affiliate. Jasmine, Tren, Shannon, and the team just made this so easy for me. So thank you all and welcome to this. I attended this about just shortly after the legislature changed all the rules. And I was really impressed with this presentation. So I hope you enjoy it as much as I did. I want to thank all the sponsors, people who have sponsored us for our conference, and then we didn't end up having it. So we will be putting on these education webinars, and this is just one of many that's going to be coming forward. But some housekeeping rules. So this is meant to be as interactive as we can with this many people and Dr. Wirjo. So raise your hand. There's a raise your hand button or down at the bottom, but I'm not seeing it, but maybe you as attendees are seeing it. And we'll unmute you to ask your question. Or you can chat the question, but remember, when you're chatting, if it's panelists and all attendees, everyone sees the question. And if it's just to the panelists, only the panelists see the question. So just keep that in mind. As far as you will be getting evaluations, and participants must complete their respective Survey Monkey in order to receive your certificates. So it's CME for physicians and providers, CEUs for social workers, and a CLE for attorneys. The links to the survey will be shared toward the end of the lecture and in a separate email following the lecture. So let's get started. Introducing Dr. Johnathan Wirjo. He's the medical director at Pavilion at Southern Hills Hospital, the psychiatry program directors for Sunrise Health GME Consortium, and the managing partner and medical director for Focus Mental Health. And he's the daddy to 2 doodles that I'm hoping we're going to see pictures of in this process. So take it away, Dr. Wirjo, and thank you so much for doing this.
Thank you very much. It's a lot easier when you have a good team on board. I literally just parked my car and walked on in and everything was set up. I was like, wow, can my whole life be like this? So hopefully you enjoy this. Hopefully you get something out of this presentation. I'll be honest, I have not given an online or webinar before, at least to nearly this many people, maybe just a handful of my psychiatry residents. And so if I'm kind of stumbling around, I apologize in advance. And on the other end, I don't think I've been able to stay awake through a single webinar. So hopefully, if you're able to stay awake, I think that's a plus and an accomplishment. Please feel free to throw out any questions, any feedback, whether during the presentation or afterwards. I'd love to hear your comments and try and field as many questions as possible, especially if the question is something that is likely pertinent to many of you out there. I will certainly address that during the presentation today. And if there are some more specific questions that might be pertinent to certain populations or certain individuals, I may hold off on answering those questions and address them at a later time, maybe in an email, or might have like a question and answer session afterwards as well. Okay, so we're gonna go ahead, jump right in. This is some CME information. It is accredited by the ACGME to provide CME education for physicians. And the HCA Graduate Medical Education Consortium designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. And please claim only what you are due. The disclosure summary, the HCA GME, we're committed to providing CME that is balanced, objective, and evidence-based in accordance with the ACGME accreditation requirements and standards. All parties involved in content development are required to disclose any relevant conflicts of interest relating to the topics of this education activity. We have established mechanisms to resolve conflicts of interest should they arise, and any potential conflict of interest will be disclosed to the audience prior to the activity, and members of the faculty and planning committee for this session have disclosed the following. And pretty much we don't have any conflicts. We don't accept any funds or payments from a variety of industries such as pharmaceutical companies and so forth. So here are some basic education objectives. We're going to discuss the key components of capacity as it relates specifically to civil commitment process and psychiatric holds. And what you will discover is that capacity to make decisions is quite a separate process and topic versus civil commitment and psychiatric holds. We will identify the rights of patients and, to a lesser extent, family members. We're going to focus on the patients during this presentation in the civil commitment process. We're going to review what the Legal 2000 process is. Keep in mind, it is not called the Legal 2000 anymore, even though I still always call it the LGK. We now call it, we're supposed to call it the Mental Health Crisis Packet. It's kind of a tongue twister, the MHCP, and be appropriately apply ethical practices surrounding Legal 2000 holds. I think as long as you know and you feel like you are doing the right thing for the individual and the community, you're probably going to be okay. In terms of commercial support, neither HCA, GME, nor Southern Hills Hospital have received any commercial support for this activity. In terms of a copy of the PowerPoint, I believe we can provide that.
Yes,
Yeah.
at the end, following the presentation.
Here are some instructions on how to claim your credits. I'm sure this information will be also provided to you afterwards. Yep. So we're going to start with an introduction. We're going to talk about some patient rights and actually go over page by page the MHCP, formerly called the Legal 2000 or the L2K. I'll admit I will probably refer to it as the L2K, but keep in mind it is now actually called the Mental Health Crisis Packet. And then some things on what to expect on the date of the hearing. And it will focus primarily from the vantage point of the provider or a member of the treatment team. For example, what kind of questions will you likely be asked by the hearing master or judge? What are some of the processes that you may expect? And hearing master Beta Yeager is on, and she will be happy to correct me about any errors that I might make. But she is the hearing master that presides over the vast majority of the civil commitment hearings. Hi, Beta. So why is this important? Let's take a look at 2005, the 10 leading causes of death by age group. And the boxes I would like you to hone in on are the green ones. And those represent suicide. Across the top, you'll see age groups. So less than 1 year old, 1 through 4, 5 through 9, all the way up to 65 plus from left to right. And then down the left column, the far left column is the rank in terms of the leading causes of death, okay? So let's take a look at the 65 plus, the second most column from the right. So you'll see that the #1 cause of death in 65 years and older is heart disease. And then #2 is malignant neoplasms, basically cancer, all right? And back in 2005, suicide was certainly already on the radar. But in terms of the total leading causes of death, it was not a top 10 leading cause of death, but it was certainly up there for the age groups of 10 to 14, 15 through 24, 25 through 34, and up until age 64 as well. We're all top 10 causes, all right? And this is one of the things that the LTK or the MACP is trying to address. How to identify those at risk of harming themselves or completing or attempting suicide, and to put them in a safe place until we can stabilize them, until the acute crisis is over, and get them back out in the community and get them functional again. In 2010, not a whole lot of changes. So I'm gonna kind of flip back and forth. So once again, take a look at the green boxes. I tried to organize it so that it kind of overlays each other pretty similarly. So if you notice that the green boxes are pretty similar. Here's 2010, 2005, 2010, 2005. So what you might notice that is that in the 45 to 54-year-old column, suicide went from the 5th leading cause to the 4th leading cause. All right. And in the 55 to 64-year-old, it remains as number 8. At around 2010, actually 2009, I believe, was when suicide emerged as the 10th leading cause of death total. Now we're in 2018. So once again, take a look at those green boxes. Here's 2018. Here's 2005. So in short, for the ages 10 through 34 years old, it is the 2nd leading cause of death. It's unbelievable. As an organism, as a species, it just doesn't make sense that we end up killing ourselves. Biologically, evolutionary, it doesn't make sense, but that is what's happening. And it's the 4th leading cause of death between 35 and 54. And it remains a top 10 leading cause of death. And rates are only increasing. So that's why the MACP and the Legal 2000 is important, because we need a way to get these people to a safe place, especially if they're unwilling to go there, even at first, okay? Suicide rates, CDC 2017 provided an update. There may be a more recent update, but in 2010, about 38,000 suicides. 2015, 44,000 suicides, and it's only going up. You have a rate increase of about 28%, and we have a particularly vulnerable population in veterans and active duty. Double between 2003 and 2008, and still increasing. For the first time in about 40, 50 years, it surpasses the rate of suicide among civilians. Starting in 2009, number of deaths from suicide surpassed number of deaths from motor vehicle crashes, 10th leading cause of death for all age groups, as you saw in that previous diagram. Firearms, most common method. How are we looking in Nevada? Well, to put it bluntly, we kind of suck, okay? Access to mental health care, 49th. Overall adult mental health, 47th. Youth mental health, you didn't think that was a 51st, huh? Well, we're 51st. Prevalence of mental illness, 45th. We're not too bad compared to the rest of the nation in terms of mental health workforce availability, all right? So there's clearly improvement to be done in terms of how we distribute and use the resources that we have. But certainly we have a pretty severe shortage, especially in terms of psychiatrists, psychiatric nurse practitioners. So any of you who are trying to help out our community, I want to thank you very much for engaging in this endeavor. to trying to help our community, whether it's in Southern Nevada, Northern Nevada, or across the country. It's much needed, and hopefully we can make some change here and provide an example for the rest of the country of how we turned our community around. So one more look. And unfortunately, it looks like suicide is only increasing in rates. I kind of want to diverge a little bit. I like telling stories because I get kind of bored talking about the same thing over and over again, but it still relates to this. Probably around June or July, my mom came to visit. And it had been a few months since I saw her. And she came out from California, she took a drive. She took the whole COVID thing quite seriously. And as we usually did, that first evening she was at my place, we sat down, had dinner at probably about 6:30 p.m. like we used to always do. And I was getting ready to eat, I was starving. And then she said, "Jonah?" That's what she calls me. "Jonah?" And I was like, oh no, now what? She's gonna lecture me on something. She's gonna lecture me about how my room is messy, how maybe it's not too late to become a real doctor and become like a surgeon or something, or maybe I should be nicer to someone who knows what. And I was like, oh boy. Then I looked up at her and I noticed, she looks sad. There's a tear forming. And what do you think I did? I literally rolled my eyes. I was like, oh my gosh, she's probably gonna talk about her divorce from 20 years ago, stuff that just rehashed over and over and over again. And I was like, here we go again. And then she actually started crying. And she told me, "Jonah, this is the first time I've had dinner with anybody in 3 months." And at that moment, I thought, wow, I think I just won the worst son in the world award for that moment. And I realized I just totally lost track of what someone like my mom and those similar in her position were going through during these hard times. I had started out the pandemic being a great son. I was calling her every day. We were FaceTiming every morning on my way to work, you know, just for like 5-10 minutes. And it clearly was helping. And after the weeks went by, I think I wasn't as diligent. And I would call maybe every other day. And it was like once a week, and every other week. Sometimes it was just a text message. And then it made sense why she really wanted to come and visit so badly. So here I am, Dr. Johnathan Wirjo, a psychiatrist. Didn't even realize that daily phone call, video call I was having with my mom was probably making a really big difference. But I didn't keep that up. I slacked off. And it was affecting one of the people that means the most to me, the person that got me to where I am today. So I ask everybody, wow, 175 people, goodness, where do you all come from? I ask everybody on this list, Justine Perez, Catherine Burning, Lindsay. After we're done, call up someone who you love, or maybe don't even love that much, and just say hi. Have them hear your voice. Reestablish some of the routines that you used to have. I know we're trying to get back to normal. The bars are open, casinos have been open. The COVID numbers are fluctuating, but it doesn't mean that we can start to slack off in terms of how we support each other, whether it's friends, family, coworkers, colleagues. Because I'm pretty sure that the road to recovery is still a long one. We got a lot of work to do. Texting is, I mean, better than nothing, but hearing a voice, seeing someone at least on a screen, for a lot of people, I imagine, mean a whole lot more. So, I mean, I tried to make it up to her. I felt really bad. And so I got our pandemic puppy. That's Kiko. He's a golden doodle. And I had already had one on the way for myself, actually 2 on the way for myself. And I thought, you know what, what's a third one? So I got a third one. And my mom had always grown up with dogs. And she was really missing that routine of caring for someone or something in her life because all her kids are gone. She was living completely alone, isolated from everyone else. So there's Kiko. He's the biggest troublemaker ever. And don't forget to wear your masks. I mean, try and wear it properly. As far as we know, I don't think COVID can be transmitted through dogs, but yeah, that's Kiko. Yeah, Sherry Boyd sent out a message, and I completely agree. Hospitalized patients or those in facilities, whether it's nursing homes, the ICU, or wherever they may be, or maybe just at home, it is very difficult when you do not interact with people the way that you're normally interacting with them. So any way that we can try and mitigate this isolation will likely help. I mean, I don't have any data on it, but I'm sure it won't hurt. So we're trying to come up with some ways to reestablish contact between family and patients or between different family members. So, and fortunately, we're in a time when technology has advanced quite a bit in the last 10, 20 years. Definitely a lot of opportunity there. I'm not suggesting everybody get a pandemic puppy, but it might be therapeutic for some of you. At least coming up with a routine, a schedule, something to look forward to day after day can help distract you from the negative things that are going on out there. Because it's very easy to ruminate about so many of the negative things. So back to the topic. So when someone does get so severely depressed or maybe psychotic to the point where they're a danger to themselves, danger to others, or they're so impaired they can't even take care of their basic needs, an admission to a psychiatric hospital might be warranted, okay? And there are a few different ways that someone can get admitted to a psychiatric hospital. One is a voluntary admission. Someone is clearly in a crisis and there is something or some things that can be done at a psychiatric hospital that can help get them back on track. And the patient has a pretty good understanding about what the issues are, what the risks and benefits are about being in a hospital, and they might be able to sign themselves in to a hospital. So that would be a voluntary admission. What we are addressing today would pertain to what we call involuntary admissions, where someone meets criteria for an acute psychiatric hospital. There's an exacerbation of psychiatric symptoms that can be addressed in a hospitalized setting, and they meet criteria for an involuntary hold. We won't really go over this third section where a power of attorney or a guardian signs them in. This is actually a little bit complex and beyond the scope of this presentation, but this is also another option as well. So once again, we're going to focus on that middle section there, the involuntary hold, okay? And that's what the L2K and the MHCP pertains to. Questions so far? I am, out of the corner of my eye, keeping an eye on this webinar chat. It's kind of cool, as long as not all 178 of you send out a question at once. All right, moving forward. So what is the purpose of having a civil commitment process? As long as you keep the core purposes in mind when you're filling out an L2K, or if you're involved in the process, it's hard to go wrong with it, okay? So the first purpose, in my opinion, is to preserve the safety of the individual and the community. Someone's a danger to themselves or to someone else, and you're trying to keep them in a safe place so that they don't hurt themselves or someone else, okay? It's not like you can just grab them and hold them indefinitely. I mean, you can do that temporarily until help comes, but you need an actual official process in order to keep them against their will. And you're essentially depriving them of their liberty, at least at that moment. So there needs to be an official process, all right? And I will answer that question in a moment. But as you can imagine, or if you know, one person can fill out that psychiatric hold paperwork. And that is a lot of power for one person to have over another. And so in order to preserve that individual's rights of freedom, the League of 2000 or the MHCP actually affords that individual due process of law so that someone other than the physician or whoever put them on the psychiatric hold reviews the case from an unbiased standpoint to determine if that person can really be kept against their will. Now, there is a little bit of a lag between the time that they're put on a psychiatric hold versus the time that the case is reviewed, but at least they are afforded that due process, okay? So one, to preserve the safety, and then it provides a means or a process to actually take away someone's rights of freedom, at least temporarily. And third, and maybe the most important of all, is you preserve that individual's rights of freedom by offering due process of law. Okay. Now, I do hear of sometimes how a hospital will ask if you are willing to voluntarily sign into a hospital. And in some cases, I think that would be appropriate. An individual who you suspect may waver between signing in versus refusing, and you really think that they are in imminent risk of harm, having them sign in as a voluntary patient may not be the best choice of action, because they might be willing to go in at 2 p.m., but then at 3 or 4 p.m., they have a change of heart and want to sign out against medical advice, and you may not be on site anymore, and then you're kind of stuck in a difficult situation where you've initially allowed someone to sign in as a voluntary, and now they want to leave, but you really don't feel like they're safe to go, okay? Does that address your comment, Robin? And keep in mind, oh, I have 2 catatonic patients at Sunrise. It's tough. When a person is catatonic, and when you're talking about true catatonia, where they're not eating, not eating, not moving, they're stuck in certain positions, and they're completely mute. Usually that's potentially a medical emergency and a psychiatric emergency, and an ambulance should be called and they'd be brought in. Or if family feel comfortable driving them to the hospital, that might be okay as well. Keep in mind, every single situation is unique, and it's hard for me to provide a guideline that is applicable to everybody, even a catatonic patient. But in general, if the patient truly has catatonia, they need to be medically hospitalized. and usually stabilized at least enough so that they can transition to a psychiatric hospital. All right. And catatonia would be an indication to put someone on a psychiatric hold potentially. All right. Once again, a purpose of having a civil commitment process is to preserve safety, have a means to preserve safety, and also to protect the individual rights of that person. So court hearings on petitions for civil commitments. The law steps in when, specifically during a mental health crisis, there's a substantial danger to themselves or others. And the purpose is to ensure that someone is not deprived of their liberty unless there is evidence that the patient, because of a serious mental illness, is one of the following, or multiple of the following: a danger to others, a danger to themselves, or they are unable to care for themselves. And it might be all three of them, or 2 out of 3, or just 1 out of 3. And one of the key parts of this is because of a serious mental illness. And we'll go into that a little bit more. There is what's called a burden of proof standard. Burden of proof, and keep in mind, I'm not a legal counsel, I'm not a lawyer, and I'm just gonna kind of keep it in very simple terms because that's what I understand it in. There's clear and convincing evidence, okay? It's not as, actually, let me just go through this slide. Clear and convincing evidence as opposed to beyond a reasonable doubt or a preponderance of the evidence. Okay, so beyond a reasonable doubt, that's like a murder trial. Okay, so you have to be pretty darn sure, like almost 100% sure, that someone actually committed a crime to convict them of that crime. On almost the opposite spectrum is a preponderance of the evidence. That's more like, is it more likely than not that this occurred? And that would be an example of, like, I believe, small claims court. Hey, I lent you $100, you never paid me back, so I'm gonna take you to court. Well, it's only $100, you know, I mean, it's a lot of money for some people, but it's only money. It's not like your physical health. It's not like you're gonna be locked away for years and years. So in those situations, it's, you know, if it's more likely that they owe you money 51% of the time, then you'll probably win the case because it's preponderance of the evidence. Clear and convincing evidence is somewhere in between those two. So maybe like 70%, 80%, sure. I hope that makes sense to you. So when these court hearings occur, in order to keep someone against their will, there has to be clear and convincing evidence that this patient, this person, is a substantial risk of harm to themselves or others, or they're unable to care for themselves, specifically because of a mental illness. And throughout all this, including the court hearings, the patient has rights. And there are a handful of basic rights that these patients have, and as you go through them, they are very reasonable. They have the right to an attorney. They can have their own attorney, or the state will assign one to them. The patient does have a right to be present at their hearing. And it's not like they can just be there and watch. They have the right to participate in their hearing, provide their side of the story. And they also have the right to confront a witness, whether it's the physician or someone that testifies saying that, you know what, this person did this and it makes me worried that they might hurt someone again, and then I heard them over the phone saying that they were going to kill themselves. That patient has a right to confront that witness. Much like a trial that you might see on TV. Okay. Keep in mind, this is under civil jurisdiction and is not criminal jurisdiction. So just going through those rights one by one. They have a right to have an attorney, and even further, understandably, they have a right to be able to talk with their attorney prior to court in order to prepare for the hearing. They also have the right to be present at the civil commitment hearing with the assistance of their attorney. And sometimes they choose not to attend the hearing, and if they choose not to attend the hearing, they have a right to know what are the potential consequences if they don't attend the hearing. They have the right to participate in the hearing either directly or through their attorney and offer any evidence that they would like to provide, whether it is through direct testimony, by testifying or calling a witness to testify on their behalf, or testimony elicited from cross-examination of the state's witnesses. For example, they are perfectly allowed to, if I was the doctor that put them on a psychiatric hold and I feel they need to stay on a psychiatric hold, they have every right to ask me questions and cross-examine me. And they do have the right to confront or face in court a witness who is offering evidence on the state's behalf and to cross-examine that witness either directly or through their attorney. Minerva, I hope I pronounced that name right. Some of the nuances. It is a nuance. I'm not going to go over the guardianship or ward of the state. In general, if the patient has a guardian or is a ward of the state, then the judge or hearing master will likely dismiss the case, although I'm not sure if dismiss is the actual word or phrase to use, but they will essentially dismiss the case, and the treatment team will need to work with the guardian, and the guardian can still sign them in to the psychiatric hospital and keep them in the hospital potentially. I do not know how or where to report a due process breach, honestly. I can find out after though. I think it's facility dependent in terms of whose duty is it to inform the patient of these rights. I know at some facilities, the hospital social worker or case manager will do that. Sometimes, I don't think the physicians do it very often, but frequently patients will ask me for clarification on what's going on because it's very confusing and quite frankly, a scary time for some of these patients, especially if they got a tinge of paranoia. And so the physicians quite frequently will step in and provide some additional clarification if needed. So once again, what rights do patients have during the hearing process? To have an attorney present at their hearing, participate in their hearing, and to confront a witness. And keep in mind, the civil commitment hearing process, they have a different set of standards than the clinical perspective. So myself as a clinician, I may feel deep in my heart that this patient really needs to stay in the hospital to get better. But the court may not agree with me, and they may say, you know what? And sometimes they'll tell me, it's probably a good idea that they be in the hospital, but they don't meet the criteria for involuntary commitment. And they might even ask the patient, you know, your doctors are recommending you stay, and we hope you sign as a voluntary, but we can't force you. Now, the two standards do overlap quite a bit. And I would say I'm just guessing maybe 70 to 80% of the time, the psychiatrists or the physicians and the court agree whether or not the patient should stay on an involuntary hold. And it kind of fluctuates. Additional requirements to ensure a fair hearing. The hearing is set within 6 judicial days, basically business days, but they're a little bit more specific because the courts may or may not be open on what most people would consider a business day. Okay, but they're very closely correlated. And there are 2 independent court-appointed doctors that evaluate the patient, provide a written evaluation to the court to provide them an unbiased opinion. Because myself, if I was a treating psychiatrist, I am inherently biased as to whether or not the patient needs to be in the hospital. Because obviously, if I don't think the patient needs to be in the hospital, I would have discharged them already. So in order to have an unbiased opinion, the court identifies court-appointed doctors, which may be psychiatrists or psychologists, to evaluate the patient and provide their own recommendation and assessment. And once again, the court does not involuntarily commit or deprive the patient of their freedom unless there is clear and convincing evidence is presented. So to put it into words and maybe feelings even, someone who says, you know what, they should probably be in the hospital and they might be a danger to themselves, is probably not enough. It's got to be clear and convincing evidence. The feeling has to be more like, I'm actually worried that if this patient leaves today, like they may not be alive by tomorrow. And these are the reasons why. And more specifically, there has to be clear and convincing evidence that the patient is suffering from a serious mental illness. And because of that illness, they present a substantial likelihood of serious harm to others or themselves, including an inability to care for themselves. We will go over some of the exclusions as well. To further define substantial likelihood of serious harm, according to NRS, it means without care or treatment, the patient is at serious risk of attempting suicide or homicide, causing bodily injury to himself or herself or others, including death, unconsciousness, extreme physical pain, protracted and obvious disfigurement, or protracted loss or impairment of a body part, organ, or mental functioning, or incurring a serious injury, illness, or death, resulting from complete neglect of basic needs for food, clothing, shelter, or personal safety. Just checking to make sure I've kind of addressed the webinar chat. This is pretty cool. It's not as awkward as I thought it would be. All right. Next part. All right, we're gonna actually take a look at the MHCP. So I'm on a team L2K. I'm not very fond of team MHCP. I think I said this last year in December. It's like L2K, it can really be used as a verb practically, and it's just got this ring to it. MHCP is kind of hard to use that as a verb. Like, yeah, we're gonna have to MHCP this individual. I'm really worried about him. But you can really say, I'm going to L2K him. But it is what it is. I guess we're moving on to, it is more appropriate to call it a mental health crisis packet. It was called an L2K because I think the original draft was in the year 2000, by the way. So yeah. So the standard of proof related to harm to, so the standard of proof, my understanding is that that's what applies to the actual court hearing in order to continue the psychiatric hold or even to involuntary commit. Now, when you're in an outpatient clinic, you should try and abide by that clear and convincing evidence, but oftentimes you're working with very limited information. So what may present as a possible mental illness crisis or exacerbated psychiatric symptoms might not actually be the case because you don't know if they're having any other medical issues or if they're currently intoxicated or how much the intoxication is playing a role. So when you don't have as much information and you really just want to get them to a safe place and you have genuine concern that any moment, especially any moment they might inflict harm because you think they're having a mental illness crisis, it would probably still be appropriate to do an L2K or MHCP. I mean, I am not jealous of police officers who are out there like on the strip and there's someone who's kind of wandering around, shouting at the sky, kind of waving something around. And, you know, is this guy just drunk? Or is he actually having an exacerbation of his voices and he's schizophrenic? It's really hard to tell out there what exactly is going on. And sometimes you just have to put them on a hold and get them to a safe place so that some labs can be drawn, a physical examination can be done by the emergency physician, and you watch them for a few hours and determine if they really meet criteria for an L2K. We can always take someone off of an L2K. Most importantly is to get them to a safe place. So I do have the June 2019 version of the L2K or MHCP. It's very similar, nothing really significant change. I think the most recent version was sent out to the audience.
It will be sent following.
Okay, that one was revised in December 2019. And honestly, I think the biggest change was that they took out the word adult on the front because it was just kind of getting in the way when you photocopy it. But I think that was the most significant change, honestly. So this will do for now. So this is the front page, the very first page of the MHCP. Oh, hi, Beta.
I just wanted, I saw that there were a bunch of questions that were maybe more legal. So if you ever need me to address some of those, let me know.
Oh, Beta, can you address, I think it was the question about guardian and ward of the state. What happens if there's a guardian involved and the patient has an L2K? My understanding is that it will be dismissed and the treatment team needs to work with the guardian in terms of a plan.
Correct. So when there is a guardianship, what that means is, and I should be specific, there's guardian of person and estate, guardian person, guardian of estate. If there's a guardian that's been appointed of the person, then that person makes those decisions for the patient. So yeah, as far as from a legal standpoint, the civil commitment petition gets denied because we don't have to make the decision for that patient. The guardian's there to make that decision for that patient.
And I think someone asked, whose duty is it to inform the patients of these rights? My answer was usually it's the social worker case management at the hospitals that I've seen deliver this information. Is there an actual requirement on who does that?
No, there's not a requirement. I mean, it's all about the due process rights of the patient, so that they need to know. So they need to have a copy of the petition, because part of the whole due process is knowing what is being alleged against them and being able to participate in the hearing. And knowing those rights is an essential part of due process. So it doesn't really necessarily matter who gives that information. It's just that it needs to be done. So the patient needs to be served with the petition. If there's a DOR, they need to be served with that as well. We down south actually produce what's called a case management order. So as soon as a petition is filed, we counterfile on the petitioner all the requirements in that case management order, which also includes that the hospital needs to make their patient available to be able to talk to their attorney, so that the attorney can also advise that patient of their rights.
Sherry, I do not know if EMTs in Las Vegas are allowed to give ketamine. Sorry. Yeah, so there is a potential for an issue if the guardian does not feel like the patient needs to be psychiatrically hospitalized, but the clinician feels strongly to keep them hospitalized. I haven't really had that big of an issue regarding that. Usually, if the treatment team, including the psychiatrist, keeps communication quite open with the guardian, my experience so far has been that they're agreeable to it, and there is always a middle ground that can be reached. Now, if there are further issues, I imagine that you could involve APS, CPS, and potentially petition for a new guardian.
Yeah, I mean, I think it would be a really good idea to consult with your hospital attorney if that becomes an issue. That would be my advice, I guess. Not legal advice, but just saying, you know, if you're placed in that precarious position, talk to your hospital attorney.
All right. So this is the first page of the L2K or MHCP, and essentially a number of individuals can fill this out. So if you look about 2/3 down on the page, you'll see written there a list of people that can put someone on an L2K. It can be an officer, a physician assistant, psychologist, marriage and family therapist, clinical professional counselor, social worker, and a registered nurse. So there are quite a number of individuals that can actually initiate a Legal 2000. And near the top is a summary from NRS about who can be put on a Legal 2000 for what reason. And I want you to look at that first paragraph. About halfway down that first paragraph, you'll see in bold, but does not include. So here is an explanation as to what can a person not be put on an L2K for. And it says any person, but does not include any person in whom that capacity is diminished by epilepsy, intellectual disability, dementia, delirium, brief periods of intoxication caused by alcohol or drugs, or dependence upon or addiction to alcohol or drugs, unless a mental illness that can be diagnosed is also present, which contributes to the diminished capacity of the person. Okay. And like I said earlier, when you first encounter the patient, whether it's out in the community or as they first walk into the ER, it can be challenging to tell what exactly is causing this diminished capacity, because you're working with a very limited amount of information. Keep in mind that you can still put someone on an L2K or an MHCP if they have dementia. However, you cannot put them on a hold because they have dementia. because there's a whole spectrum of severity of dementia symptoms, right? So you can have someone who technically has a diagnosis of dementia, but they also can get depressed. Schizophrenics can also develop dementia, but if their inability to care for self or their danger is because of a mental illness, and they happen to have dementia or intellectual disability, they can still be put on a psychiatric hold. So I think that's a very important distinction to make, okay? So it's not technically exclusionary. It's not like, oh, they have intellectual disability that we previously called mental retardation. You can't put them on an LTK. That is not necessarily true. Because even people who have an intellectual disability, they can encounter social stressors. They might have schizophrenia. They might have major depressive disorder. It might have an exacerbation of their symptoms. And because of that, they're at risk. As long as you're not putting them on a psychiatric hold because of delirium, intellectual disability, dementia, okay? And sometimes it can be hard to differentiate. Epilepsy, it really kind of falls under delirium. When someone has an active seizure or they're post-ictal or that period of time right after a seizure, they can be confused and disoriented. Some certain types of seizures can also have psychiatric-like symptoms. If you have a seizure in temporal lobe, they can have disruptions in some of their perceptual disturbances. And if you know that, oh, it's their temporal lobe seizure that's causing these perceptual disturbances, they technically would not meet criteria for a psychiatric hold. However, if they're at a place where their medical history isn't known, it's very possible that they be put on a psychiatric hold because they don't know this person has a history of seizures. But hopefully during the medical workup, that is uncovered. All right. Yeah, so as B.D. Yeager mentioned, there is a provision where a family petition can be filed. I don't know the nuances and the details regarding how a family can petition to be filed, but that is an option. It honestly isn't an option that's used very much, and in some circumstances, it might be appropriate. And I will address that statement regarding hearing to be held within 72 hours, because that is not the case. All right. So the person that's filling this out needs to identify which of those checkboxes, one or more, that apply to this case. And it's attempting suicide, attempting homicide, causing bodily injury to himself or others, or incurring a serious injury because of complete neglect. Okay. And then that person needs to hopefully provide as much information as possible to justify why they're initiating the Legal 2000. And identify who they are and their Nevada license number if you have one, and then sign it, date it, and time it. So the name of the patient goes there. Identify what is the type of risk being identified. Describe the observation. And I can tell you, the best descriptions come from police officers. Right? I mean, they'll fill up that whole section, even put in the phone numbers of collateral information. It's great. When I see an LTK filled out by a police officer, thank goodness, I actually have some information. The worst ones, you know who? Doctors. They'll put in SI. They wouldn't even write out the whole name, the word. They'll just put like SI, and it's kind of annoying, but yeah. So thank you, police officers, for actually doing it correctly and then filling it out. But you do want to help out whoever takes over the case later on by providing as much information as you can, okay? So for example, an example of what might be included is, quote, patient reported to multiple family members that he was feeling increasingly depressed over the past 2 weeks and having worsening feelings of hopelessness, poor appetite, and more frequent, intense, intrusive thoughts of suicide, and had written a suicide note. So that provides some good information as to why you're putting someone on a psychiatric hold. Or another possibility is a patient has reported history of schizophrenia, been off his medication for 2 months, and was found wandering outside without adequate clothing to stay warm, preoccupied, responding to internal stimuli, at times agitated, throwing rocks at cars, believing that they were following him, and was not attending to his basic needs. Okay? If you can provide descriptions like that, you will be way ahead of the curve in terms of filling this front part correctly. And then you sign, don't forget to date it and time it, okay? And once this is signed, that's when the 72 hours starts. And the 72 hours, unfortunately, it's often miscommunicated to the patient. It's not that the patient can only stay for 72 hours, nor does it mean that the patient needs to stay for 72 hours. It just means that within 72 hours, a petition needs to be filed with the court, letting them know, hey, we're keeping this person against their will. We need to make sure that their rights are preserved. Let's put them on the court docket so that a third party, unbiased, can review the case to determine if the patient meets criteria to be kept against their will. Okay? All right. Now, when a patient presents to the ER and they're on an L2K, let's say Metro put them on an L2K, usually the ER physician will evaluate the patient. And this top section is kind of confusing. Sometimes it's easier for me to just talk on the phone about how to fill this top section out. And it's really mainly for physicians, PAs, nurse practitioners. If the medical workup is complete and there's no medical condition that would account for the psychiatric presentation and they seem stable enough to be transferred to a psychiatric hospital, then they would actually check this second box saying that this patient has no medical condition or disease other than a psychiatric condition that requires hospitalization or treatment, and they sign it, and that would be considered a medical clearance. Okay? The first box is in the event that the patient actually needs to receive medical treatment. And so in that case, a notification will be sent to the court saying, hey, a psychiatric hold has been initiated, but we're actually admitting the patient for medical treatment, but we're just letting you know that we're keeping this person against their will. Okay, so the court kind of keeps an eye on that and may visit the case periodically to determine if they really meet criteria. This, in a way, was to address a potential loophole in the previous L2K where someone who isn't medically cleared wouldn't have been petitioned because the certification wasn't signed, because the thought was that you can only certify a patient once they're medically cleared. Okay. But let's say the patient has been medically cleared and there's another evaluation. This bottom half of the second page will essentially complete the L2K, all right? So if they're medically cleared and the evaluator, let's say the physician, determines, you know, this patient is still in imminent risk of killing themselves, they would check that first box saying that this person is a person in a mental health crisis and describe in detail the behaviors that were observed, and then sign it, indicating that patient's medically cleared, still meets criteria for a psychiatric hold. In my opinion, they need to go to a psychiatric hospital. All right. There is an option to decertify it on this section, which is kind of a confusing part for a lot of places, and I can see why it's totally confusing. You can actually decertify it by checking that second box saying that this person is not in a mental health crisis per NRS. Or the patient might be initially certified. They might spend about 3 or 4 days on the medical floor, and while waiting for a hearing, they actually get a lot better. Maybe the drugs have exited their system. They're restarted on the Risperdal. They have an underlying history of schizophrenia, and they're well enough to be taken off a psychiatric hold. The third page can be used to eventually decertify the patient. All right. So just to recap, I know the lingo and the jargon can be confusing. This top part is the medical clearance. The first box is if you need more than 72 hours to medically clear the patient. Let's say the patient likely has cellulitis that needs IV antibiotics. That might take more than 72 hours. Or the patient's medically cleared, ready to go to a psych hospital. And then it's certified, and then description and some more signatures. All right. So once this whole section is filled out, the patient is either discharged from the psychiatric hold or referred to an acute inpatient psychiatric hospital, assuming that they're medically cleared. This is the third page is the certificate of release, saying that, you know what, I don't think this patient meets criteria for a psychiatric hold any longer, and I feel like the patient can be released from the psychiatric hold. So from what I remember, Amanda Gordon, there's actually a very, it's not a too complicated process where a licensed clinical social worker can request for a certification to be able to release psychiatric holds. And it should be on the Nevada Board of Social Workers. I've seen it there before when I looked a couple of years ago. Because I have a few social workers that work with us, and they were able to get that approved. They would need to have a clinical license in order to decertify a psychiatric hold, but not necessarily to initiate a psychiatric hold. And yes, police officers carry this form. I don't know how they access them. They probably just have them in their cars. Megan Jensen, the outpatient clinic should send all the pages with the EMTs. Oh, yeah. Well, now that we're in COVID and a lot of encounters are done telemedicine, it is an issue. Typically, we would call Metro for a wellness check, and Metro hopefully will take into consideration the information that you provide them and what they see on site, and Metro may or may not put them on a psychiatric hold. All right. So once the petition has been filed, within 6 judicial days, a court hearing will be set. What can you expect on the date of the hearing? They might ask, how's the patient been doing on the unit, whether it's a psychiatric unit or on the medical floor? We're reading something in the medical chart or the psychiatric chart about some aggression in the unit. Can you give us more detail? What exactly is going on? I know you've mentioned that there is some concern about danger to self. Once again, can you give us more detail? And they're looking for what is the severity of this concern? And how imminent might it be? And are they actually engaging in self-harm behavior on the unit? And of course, since the psychiatric hold needs to be justified by a mental illness that's causing their imminent risk, what is the primary diagnosis that you think is accounting for this risk? What is potentially a discharge plan? And are they compliant with their medications? And this is a question that I hear all the time. The lawyers that represents the patients and Beta Yeager will ask, so what does this mean, the inability to care for self? Can you elaborate on that? So if you do accompany the patient to court, be prepared to field some of these questions. If patients are cleared, does a clinician have to redo the certification part after signing the release? Are you talking about medical? So let's say the patient is taken off the L2K and then 4 days later they're medically cleared. Is that what you're asking? Well, if they sign the release, which is the third page, then the patient is off the psychiatric hold. And Olivia Flewellen, if a social worker initiates a hold but does not work in a hospital setting, do they have to go to court? Typically, no, because there has to be some representative from the treatment team that accompanies the patient to court. That's my understanding. But it would be difficult to have someone who had initiated the L2K who's not actually on site to attend court. But it is possible that someone might be called as a witness. It doesn't happen very often, though. And can you explain what to do with an intoxicated patient who is making suicidal threats in a medical hospital? Can you initiate the hold and wait to certify when sober? This is a tough one. I mean, in the end, you're going to keep the patient against their will, okay? So if they're severely intoxicated and they're not able to demonstrate understanding of the risks and benefits of medical treatment, what the risks are if they just leave the hospital, you could keep them on what's called a medical hold. And a clinician would need to document the patient does not have capacity to sign out against medical advice. Now, if there is some concern that there's an underlying psychiatric illness that is prompting this behavior and they happen to be also intoxicated, then you could initiate a psychiatric hold, but the right thing to do would be to reevaluate the patient once they're sober and determine if they're still a threat. And at that point, either certify or decertify the psychiatric hold. You should not certify a psychiatric hold when the patient is still clinically intoxicated. I would advise you not to do that. Does that answer your question? So the same person can initiate, medically clear, certify, and decertify the Legal 2000. Imagine some of the rural areas, there may only be one clinician, and it'll be very difficult for that person to find someone else to fill out another part of the Legal 2000. So yes, the same person can fill out the whole form, start to finish. So on the date of the hearing, what decisions can the court make? They can release the patient, say, I'm sorry, we disagree with you, treatment team, we disagree with you, Dr. Wirjo. We don't feel that the patient meets criteria, and I'll pout, and then they'll be like, okay, that's the way it goes. And the patient will be released. Another option is that the court might determine that the patient meets criteria for commitment and they commit the patient for 6 months. That doesn't happen very often. What usually happens is that the patient is either released, or the third option, the decision is postponed for a certain amount of time. Perhaps the patient is engaging in active treatment, they're showing some improvement. We really don't want to commit them for 6 months. Let's take a look at them again in 1 week, 2 weeks, 3 weeks, 4 weeks, and see how they're doing. So that is a very common decision that the court makes. Megan Jensen, I'm going to take a stab at that question. If patient is being seen by an unlicensed provider and has consulted a licensed supervisor via video conferencing and deemed the MHCP appropriate, can the unlicensed provider sign the MHCP using licensed provider license number? I would say no. S. Harris 045. Once the third page release is signed, that's done. Nothing else needs to be done on the L2K. All right. Oh, we're on the question section. So hopefully I haven't thoroughly confused everybody even more. But it can be a convoluted process unless you deal with it on a daily basis. And imagine you're a patient and you're having a psychotic process going on, or you're under the influence, or you got some delirium from medical illness. I mean, it can be even more confusing for them. So whatever perspective you're coming from, whether it's advocating for the patient or being one of their family members, which is great. I'm glad you're attending this if you're a family member or a concerned loved one, because this is important for you to know. Or if you're a mental health professional, knowing this process can help you better advocate for your patient and really alleviate some concerns and anxiety they may have as they're going through this process. Is there a statute reference for medical hold? I do not believe there is a statute reference for medical hold. Beta, if you can confirm that. That's really a medical practice.
Actually, it's under 433.165.
Like I said, it's under 433.
Oh, sorry. I'm talking about the medical clearance. That's the, I don't know medical hold. I'm talking about the medical clearance part where a patient is being treated for a medical issue while they also have that mental health crisis situation. Is that the question, or are you talking about the medical hold within
I think they're talking about the medical hold. So physicians will sometimes initiate a medical hold, and this is not a Nevada thing. It's just kind of our just profession-wide. If a patient, for example, comes in, they have a head injury, okay, they hit their head, they're refusing a CAT scan, they think they're on the planet Mars, and they want to go to the birthday party of their deceased great-grandparent, you know, clearly they shouldn't be leaving the hospital, right? And they don't meet criteria for a psychiatric hold, but you would keep them on a medical hold, saying that they do not have the capacity to leave against medical advice, and you would keep them against their will until they regain that capacity. That is a different process and series of lectures in itself. That would be different than a psychiatric hold. Alana, oh, never mind. Would I do anything different if the patient is homicidal? If the patient, not really. If you're discharging a patient that is potentially homicidal, as a clinician, I would notify the target, if at all possible, if there is an identified target, and potentially notify law enforcement. Keep in mind that being actually homicidal is not necessarily the same as someone having thoughts of hurting someone, okay? Having aggressive thoughts towards someone isn't necessarily abnormal. It's whether or not you act on that. We're human, we have emotions, we have those automatic thoughts. But whether or not we can take a step back and let it calm down, that's what determines if it's pathologic or criminal versus just a normal human thought process. Once again, thank you everybody for attending. I think just it makes me optimistic when I see this many people trying to learn more about mental health and about this process that's very confusing, especially to people who are not dealing with this on a daily or weekly basis. And hopefully one day we'll all be able to see each other in person and it'll be back
So
to
if I
normal.
could, Dr. Wirjo, thank you so much for everything that you've done. And you were so worried about having no one in front of you and all of this, and you did fabulously.
Thank you.
So again, thank you so much. And I'm so glad I got you to agree to let me record it.
I forgot one more slide.
Oh, the most important one.
Yes, that's my mom. And the one on the left is Kiko. And the one on the right is Puka, P-U-C-A. And they're golden doodles and they keep me up all night.
How's puppy training?
It's hard work. Goodness.
If someone on a hold and not in a hospital setting, when you call the police or for transport?
When you call police for transport.
Yeah.
If they're on a hold, okay, the question is, if someone is on a hold, a psychiatric hold, and they're not in a hospitalized setting, who would you call for transport? Typically, I would just say, call 911. And it's usually a medical transport, the way it's going right. I'm not saying that's the way it should be, but usually it's an ambulance that would transport the patient to the ER. And it's rare that police officers will actually transport an LTK to the hospital.
But also know that when you're calling 911, explain to them that, you know, this is a psychiatric or a mental health condition, because a lot of the law enforcement do have the most teams and CIT training, and they can make sure that they're sending the right people out.
Yep. I believe, yes, the recording should be available. You could share everybody what my dogs look like.
And what your mom looks like,
Yes.
you know.
I'm visiting her this weekend.
Good for you. You got to give her a hug.
Yep, absolutely. All right.
Thank you so much, everyone. You'll be getting those emails with links. I think Shannon's supposed to share the links again. to everyone so that you can have them right here. Unless I read my cheat sheet wrong. Oh, there they are. They're in the chat.
Thank you to Beta Yeager for coming by.
Yes, Beta, thank you.
Anytime.
So I don't know how better to end this, but you're getting tons of thanks. You just have to keep looking at the chat. Look at that.
Yeah, I might do this again. It wasn't too bad.
Yay, that is a success.
All right, stay safe, everybody.
You too. Thank you, doctor.
What did you want?